Okay, now can you see it now?
Now you are, yes.
Okay. Okay, and I can see you guys, so thank you. So the big recommendation that's coming out that will change our practice, especially nursing practice, is that they're trying to get away from the estimated blood loss. They're finding it's very inaccurate. And the treatment for postpartum hemorrhage is based on the blood loss, basically. So the first point of order, well, there's actually a point of order before that prenatally, but in terms of change of practice, actually having a weighed blood loss. And in the supplementary package, there's all these forms and all this help to actually be able to quantify and measure and so on. So one of the things they're recommending, which I was going to email you about, Erin, is, I don't know exactly what it's called, but it's like a catch for the birth, so that you can actually catch the amniotic fluid with the birth, to try to differentiate that between the bleeding. And they're recommending that you mop up the floor quite quickly after the birth of the amniotic fluid. So you can kind of take that out of the equation as much as possible, and then quantify the blood loss more effectively through actually measuring it. So, it is a change of practice for nurses, and you have to be quite on top of it. It's kind of like what I see in the OR when we're measuring blood loss in the OR, kind of translating that into the delivery room a little bit more. Is there any questions about that?
Tanya, have you thought about how this is going to apply at home births when we don't have standard weights of things?
Well, yeah, well, they have, I would try to standardize it as much as possible, basically, in terms of receiving blankets and so on. It's going, like, your care, well, you do need a good estimate. Like, you can bring things in, like I usually bring in all our soiled stuff if it's significant, to try to figure out the estimated blood loss or the actual blood loss when we get there, because you're so busy anyways, like you don't have the button to push to bring in people to help manage that.
And my next question was also home or hospital. How about water births?
How about water births? Well, that is the basic question in terms of whether people are delivering placentas in the water. And generally our practice is to not deliver placentas in the water. So, the baby comes out, you have some time with the mom and baby, and then you do delivery of the placenta on land, and then you can estimate it better. It is really difficult to estimate blood loss in the water, and it's basically for that reason. Germans have like this special color chart that supposedly tells you that. We don't have anything that fancy, and I don't think it would be that defendable. Any other questions? And again, we'll go over this later, but it's always like, if the woman says, no, I'm not getting out of the tub or something like that, this is recommendations. This is if she's low risk and different things, then, it's more of a discussion, but at least you had this discussion and it's charted, right? And so you're always thinking this, because again, postpartum hemorrhage is the most common complication of obstetrics, and it's increasing, which I'll go over. The other big things are so regular 10 units of oxytocin for active management or for treatment, and then a three unit IV push. It used to be 5, so it's just changed to 3, and that's a rapid push. And so there's a new fancy, and we'll go over a new fancy way to actually determine what's the maximum allowable blood loss that is allowed basically for a pregnant person. And the recommendation is actually to do that in advance for every delivery. And so it's quite big. It's like 3 or 3.5. It often ranges between 3 to 4 liters. But that's when, you should definitely be calling for blood at that time once they're close to the maximum allowable blood loss. And that assumes that you've already given a number of saline or fluid replacement. So this is like you've already done all the management, but if you're getting close to the maximal blood loss, then you really need to be thinking about giving blood. And then misoprostol, I don't know if anyone's still doing it rectally, but that is out. So, and misoprostol, and we'll go over this, misoprostol and TXA aren't really considered second line uterotonics now. They're kind of considered part of the first line. Okay, so some of the key messages that it is including is that they're recommending a risk assessment, which we'll go over prior for every person going into labor prior. So it includes whether what they're at risk for, basically, or whether they're at risk, and if they are, kind of what to consider, and also calculating the maximum allowable blood loss, which seems a lot. And so a lot of this was actually taken from the California, I think it's on my next slide, but it's a California quality control where they was able to reduce their kind of extreme postpartum hemorrhages needing blood transfusion by like 20% by following some of these very clear and thorough procedures. And so it's transferred over to Canada with that. So the key thing with preventing morbidity is to try to recognize it as early as possible. And so that's why they're really encouraging calculating the blood loss, because there's thought that due to the estimation we're underestimating significantly, we're not moving quick enough to treat the postpartum hemorrhage. And then they're really encouraging SIMS and debriefs. So, and the simulations, like we all know SIMS, the debrief, there's actually a very clear outline and guideline that I shared at the end of the supplementary package. And, you know, it goes step by step and kind of what to discuss and checklists and so on. So that is, any questions about this stuff? Okay. So the incidence with measured loss is about 10% of all births have a postpartum hemorrhage, or 5.6 per 100 if you're just doing with the estimated blood loss when you just tick the box and say less than 500 mils or over. And then the rates are rising, and they think it's primarily from atonic uteruses. So, but even when they have they've controlled for oxytocin use, they've controlled for age, they've controlled for everything that they can think of in terms of what might impact the increased rates of postpartum hemorrhage, it's still increasing and they don't know why. So again, this is an important thing to address. And then 60% have at least one identifiable risk factor, and we'll go over the risk factors that they consider. So this is what I was talking about in terms of the California Maternal Quality Care Collaborative. So they use a bunch of R's: risk assessment, which we'll talk about, risk reduction, recognize and reevaluate, react, resuscitate, and review. Any questions? Okay, so one big take home for me as a primary care provider is we need to do a lot better about treating iron deficiency anemia in pregnancy. So basically 91, I have iron deficiency anemia that I have been trying to deal with my whole life, and about 91% of us actually have iron deficiency anemia, which they define as a ferritin less than 50 micrograms per liter. So when you're considered anemic and you have a baby, or you have a normal spontaneous vaginal delivery, you have less hemoglobin reserves, which we all know, so less ability to carry oxygen to all the cells. But the things I learned is that with reduced oxygen, your muscle doesn't work as well, right? So that is common sense. So it's just the risk factors of having the atonic uterus is higher. And because of some physiological issues apart from oxygen, iron deficiency is also associated with uterine atony. So it's kind of a triple whammy. And so, you know, whatever we can do to increase the hemoglobin prior to delivery is really important. So they recommend oral iron salt supplements. There's no better or worse in terms of ferrous gluconate, ferrous sulfate, and all the fancy ferruses. in terms of absorption, there's no better or worse. It's just mostly what people can stomach or not, because sometimes it can cause quite a bit of nausea, and it can cause some constipation as well. And so this is the thing that we don't jump on probably quick enough. They're saying if there's no change within 2 weeks, then we should be starting IV iron transfusion. Like we usually give 3 to 4 weeks and then sometimes change it up and so on. And so they're suggesting to start sooner. Birthday, sorry.
Birthday, yes. But the supplementation you make, that depend on the hemoglobin, not the ferritin in pregnancy.
Yes. Yeah, we're working with the hemoglobin, but they say to still check ferritin with every time you're basically checking the hemoglobin, because ferritin takes a lot longer to change and to go up, and ferritin is it's not the best lab indicator for, especially for acute situations. So if you have a cold or if you have some kind of infection, it will increase due to inflammation. So it's kind of like an inflammatory marker, and it's not good if you're in an active postpartum hemorrhage. But generally, you know, if you're like, I'm actually trying to be preemptive, because usually people are on the edge. They have low ferritins or, you know, above 12, which is reasonable, and their hemoglobin's reasonable. But you know, by 28 weeks, when we check it again, that their hemoglobins are going to drop and need iron supplementation. I'm trying to be a bit more proactive and be like, look, like you're okay now, but you're just on the edge. It's probably worth your while to start iron supplementation now, rather than waiting until it's quite low and then have to build it back up. Tia, hi, nice to see you.
Hi, Tanya. I was just wondering how accessible IV iron transfusions have been since COVID. Previously, they had been anything less than 110, but currently in the Vancouver practice, unless it's less than 80 for hemoglobin, and or if it's signed off by OBIM is the second. So typically we would look at and make a case for social complexity, and argue the case, even if it was, for example, 112 and it's the first trimester. And so I'm just wondering in other communities what that looks like. And if not, then sometimes I would recommend people seek out private pay options, and then the evidence around the IV iron transfusions, and then there's a couple different options.
Yeah, it's so the concern with IV iron transfusions, there's two different options. The cheaper option has a significant, not high, and I don't have it in front of me, but it has a much higher risk of anaphylaxis. And so we generally, like if you're doing it in the hospital, they'll give the expensive one. And in our hospital, IV iron transfusion is the second most expensive drug there is. So we're allowed to do it less than 110 with a ferritin less than 10. And we have to show our lab values, and then we can get it done. 80 is very low. Like I would show them the SOGC guidelines, but I understand capacity is an issue. But our problem is we have to get it done in the chemo lab, and it's not always fun for pregnant women to have to sit, and they have to go usually 3 or 4 times to go sit with the chemo patients to get their IV iron transfusion. So I feel like this could be worked out well, or it could be worked out better for sure, to support, especially for a high social risk women, to support them to get the iron transfusion easier. Any other questions? Sorry. Yeah, and then they recommend still continuing oral iron for 3 months postpartum, and then consider IV iron with a hemoglobin less than 80. That's actually when they used to start blood transfusions with a hemoglobin less than 80 about 10-15 years ago. Oh, actually 20 years ago. Sorry, I'm dating myself, but about 20 years ago. But now it's down to 70. So like 70 or less, they recommend a blood transfusion, and between that, then IV iron. So that's why you've probably heard some bad things about IV iron use, and it's mostly because they're using the cheaper stuff. Oh, and I've actually started for me personally, and I've been recommending it to some of my clients, is something called the Lucky Iron Fish. I don't have any, I don't make any money from it, but the Lucky Iron Fish, they call it a fish because it's often used for Asian populations. And so it's just like a block of iron, basically, that has certain properties to it that can absorb better. And you can boil it in water and just drink it that way with some acidity, or you can cook with it a little bit in your food. And so I've actually had good results for some women using that. And they usually get less side effects in terms of the constipation and the nausea. It does take a little bit more work and effort to do, and it's about $50, but it lasts for 5 years. So, in the long term, it can actually work quite well. I was going to say one other thing about that, but I forgot. Oh yeah. So a lot of times everyone says, oh, we're taking iron with their prenatal vitamin. That iron doesn't really count. It's not going to absorb well, because usually there's calcium in it too. And often it's the prenatal vitamin, because there's so many vitamins and minerals in it that's causing kind of the nausea and unwell. So sometimes I'm just like, just drop the prenatal right now, take some iron and folic acid, or iron and a B complex, and we can bring the prenatal vitamin back in later. But it's actually more important to take the iron than the prenatal vitamin, in my view.
Hi, I just have a quick question with the iron too. It's my understanding too, to help absorption of iron, is it not also recommended that they take it with some sort of vitamin C content, and that tends to help the absorption part too for some people?
Yeah, that was the case. It's kind of out the window now. It doesn't hurt.
Okay.
It doesn't hurt to take it with things, but the evidence, and the other evidence that's also now out the window, it keeps on changing.
Yeah, of course,
is to take iron every other day. So that's what I've told people for years. And supposedly there's an enzyme that if you take it every day, it can block the absorption of enzyme. The new research on that suggests that it doesn't actually help it doesn't change absorption, but they might be able to stomach it better, basically, if they take like alternating breaks. So, I just tell women, like, whatever works for you, like, as long as you take it. Like, often I say every day because they forget it and they end up taking it every other day anyways. Like, it's like, you can try to take it, but you don't have to be diligent with this stuff as the research continuously changes.
The fish, you just tell people to throw it in any fluid that they use?
For the Lucky Iron Fish, yeah, you put it in just like a water, you can use it as your water bottle, or you can put it in sauces if you're cooking. Like, if you're cooking anything that needs water, I put it in all my stews and sauces and so on as well. I always have iron water around, because iron deficiency anemia, it's not just an issue for a woman, it's the leading cause of learning disabilities for children. So iron deficiency anemia is throughout, and that is why they recommend introducing solids basically at 6 months, because their stores that were taken from the pregnant person, have been used up by the 6 months, and then you're trying to introduce iron. But so iron's important all around. So, it's a good time, especially as a primary care provider, just to set the tone for why iron is so important.
Thank you.
Anyone else? Okay, so this is the new thing. This is in the supplementary package of the SOGC guidelines. So this is the new thing in terms of calculating the maximum allowable blood loss, also known as MaBAL. And so they recommend doing this for every person, and then filling out the checklist in terms of which risk category they are. And then, just of note, for elevated BMIs or severe preeclampsia, there's less blood volume expected circulating. So that is why it's reduced for them. And so there's actually, it's in terms of medium risk and high risk, there is there are quite a few factors, especially when you get to intrapartum, that would put you kind of in the medium risk factor. Sorry, would actually put you in the high risk factor. So prolonged labor, prolonged use of oxytocin, and prolonged second stage actually indicates a high risk. So, you know, there's a lot of people that we are thinking in our back, oh, they're at higher risk of PPH, but this actually helps delineate it a little bit more and just ensure that that all the steps are being prepared and taken in advance. Oh, so when I was talking about the catchment thing to collect amniotic fluid volume, it's called the calibrated drape for delivery. So that's, or there's a catchment, and then you can also like have a drape that actually, when you fill it up, like can actually determine the blood volume a little bit better. Okay, so we'll go over this a little bit more and so postpartum, you know, these are risk factors that you're wanting to look at a little bit more postpartum in terms of quick delivery, and then an assisted or cesarean, low platelets. You can read all this. Okay, so, and you can always just say, look, I think they're risk factors. This isn't inclusive, but we should just be a little bit better about, as a team, really determining where their risk status is. So this is just an example of calculating some maximum allowable blood loss. So a 32-year-old gravida 1 with a previous low-lying placenta, 75 kilograms with initial hemoglobin of 115, and so her maximum allowable blood loss would be about 3.6 liters, which is a lot, but you can actually use that fairly quickly. So what risk factor would this person have? Think about that.
The low-lying placenta.
Yeah. So low-lying placenta is considered a medium risk. And why is it considered a medium risk?
Because it's closer to the cervical os, maybe, and we know that the contractibility of that area is not always as good. So maybe you're also thinking like ergot and some other, which uterotonics kind of focus on the lower segment of the uterus as well.
Yeah, totally. There aren't any oxytocin receptors in the lower part, in the lower segment. So your natural oxytocin and any oxytocin that we give works well for the upper, but it doesn't really do anything for the lower segment. And the worst postpartum hemorrhage that I have had in my life was previous low-lying placenta. So I will always remember that and pay attention, because that's how practice works often. And then an example of a BMI of 30 over 35, which is, you know, a significant portion of our population when they're pregnant, has a BMI of over 35 and a history of postpartum hemorrhage. You're looking at the maximum allowable blood loss of about 3.4 liters. So, and then the risk factors for her would be pretty clear. Prior PPH. I don't actually know if they have elevated BMI as a risk factor. They don't put that as a risk factor for bleeding. In the SOGC obesity guidelines, I do believe it does include elevated BMI as a risk factor for bleeding. And that's just because sometimes their uterine muscle can be more discordant as well. But it's more our ability to really determine whether the uterus is atonic or not, because it can be a lot harder to actually palpate the fundus and determine whether it's well contracted or not. Any questions about this maximum allowable blood loss? I know this is more work for overworked nurses and people. So I would maybe start small, especially people with risk factors, and go up, but this is the new recommendation.
Sorry, on the I'm assuming SOGC has like a 1-pager worksheet with this on it, with the calculation, etc. included.
Yeah, this
Okay.
whole thing like that I just showed, it's in the supplementary package, but it
Oh,
has,
okay.
yeah, it's
Yeah.
a 1 and a bit page, unfortunately, but it does have that.
Okay. Thank you.
And so the other piece of this that the SOGC is really trying to hone down is now they have very clear different stages of postpartum hemorrhage. So stage 0 or not a postpartum hemorrhage would be a normal blood loss, which averages about 300 mils for like a normal normal spontaneous vaginal delivery, which, you know, the body has good, especially the pregnant body has good physiologic processes to deal with that amount of blood loss. Stage 1 or mild postpartum hemorrhage. So you'll note that the only difference in between stage 0 and stage 1 is the heart rate. And so this is often what changes first, is there starts to be a tachycardia. And then you don't actually see changes in blood pressure and stuff till usually they've lost about 1/3 of their blood volume. So blood pressure is so late, and we focus so much on getting blood pressures, and we're not usually really looking at the heart rate as well as we could be for maternal. So the recommendations, which we'll go over later in terms of how to manage each of these stages, now includes ECG, at least for stage 2 or stage 3, to put on an ECG, because you want a proper readout of the heart rate. And you could, or it's just easy to put on a pulse ox, because they're also recommending a pulse ox and have the beat to beat heart rate, because for me that's what I'm looking for first too, is, you know, I'm looking at the heart rate. If anything's changing, that's the first sign that will, and that's just the first line uterotonic, you know, which you guys all know, but we will go over as well. And then it goes step by step. So today, in just this case, in this case review, we're just going to keep at stage 1. And then next week, I'll go over stage 2 and stage 3 a little bit, but I'm not going to go over any of the surgical management or any of the fancy stuff with postpartum hemorrhage, because that is not my specialty. But they do go over it in the guidelines. Any questions? Okay, and in the supplementary package, and I'll go over the stage 1, there's a very clear checklist in terms of what to do at each stage for the nurses, basically. So it's just clarified things as much as possible, which is great. Just a little bit more information, active management of 3rd stage. So they've changed the definition. It just means giving a uterotonic prophylactically now. So it doesn't include early cord clamping, because we all know that the recommendation is delayed cord clamping for a variety of reasons, mostly that the babies get transfusion of blood, which is very important. And controlled cord traction has actually been removed, which is surprising for me, as what's called active management of 3rd stage. And from what I can gather, it's because people aren't doing it properly. So they're doing controlled cord traction without signs of separation of the placenta, and without knowing that the uterus is well contracted while doing controlled cord traction, which can cause more problems in the long run, in terms of if you actually prolapse the uterus or anything like that. So it's not saying that you don't do it, but you know, the provider should have the skills to be able to know when there is a placental separation and when the uterus is contracted enough to be able to actually deliver the placenta safely. So this is my friend out. And that it's not like give the oxytocin and start yanking on the cord. And also, you know, we are very stuck on active management, and there was good research, and now the new review for people with low risk of postpartum hemorrhage. These are poor quality studies, so they put many caveats on that, but there's actually not a clear benefit of routine uterotonics or medication. So it is very valid to have an informed choice discussion for people who are choosing not to do active management of 3rd stage. And if they're low risk, you know, it's likely okay. We always talk about it like we're always doing a risk assessment. It's not just like one conversation and done. But there might be things that come up in labor, anything with the birth or the bleeding that would contribute us to revisit that question. Oh, my son wants to join us for the presentation. This is Cheyenne. And then, oh, and if they're choosing what we call physiologic management of third stage, we definitely don't do any controlled core traction in those respects. So often we'll need to use gravity, nipple stimulation, or baby at the breast, or different things to deliver the placenta. But the risks of doing sometimes, you know, we'll follow it up, and if the placenta is right there, then it feels safer to do just a little bit of controlled core traction, but generally we try to avoid it with physiologic management. Any questions with active management? Okay, so the evidence is that the more we use oxytocin, the higher chance there is needed for a second line uterotonic. So that's ergot and Hemorrhage or carboprost, which we will talk about next week. So just recognize that, of course, they're at increased risk using oxytocin. And this was new news for me, is that when the maternal fetal condition is stable, so with labor dystocia or something like that, they suggest considering a washout of oxytocin prior to delivery or prior to cesarean delivery, especially those with the BMI over 40. Because I think their oxytocin receptors are more. So, you know, just make sure to stop the oxy if you're going to. And you know, in my hospital, by the time we actually get them to the OR and the baby delivered, as long as we stop the oxy ahead of time, that's likely. It doesn't tell you how long the washout should be. You know, I'll go over it later, but the oxytocin half-life is like 4 minutes. So, you know, it doesn't have to be that long, but if you can, stop the oxytocin ahead of time. Any questions? Okay, so we're just going to go through a case study. So Nicole is 28-year-old. She's 100 kilograms at time of delivery, gravida 1. She was treated for iron deficiency anemia in pregnancy with oral iron. Her most recent hemoglobin was 108. She went into labor spontaneously, and she was augmented with oxytocin and had a 3-hour second stage. So what risk factors are there?
Hemoglobin below 110, low progress in second stage, and needed augmentation.
Yeah. And so then if you go to the preparations, it's here on the 4th column. So CBC type and screen. So generally we should be doing a CBC type and screen anytime we start oxytocin now. Like that is within most frequent orders. I believe. Review postpartum hemorrhage checklists. Notify obstetrician and anesthesia. Hopefully, you know, you've notified the OB if you're pushing for over 2 hours, but you know, anesthesia was new for me. Okay. Talk about blood products and consent patient, which often we're doing already if we're doing a type and screen. Calibrated drape and active management. So, you know, stuff that we're doing already, but it's nice to just have it clearly written down just to make sure we don't forget anything. Any questions about any of that? Where am I? Okay. Oh, we talked about active management already. So she just had a normal spontaneous vaginal delivery, and she received active management. What are the next steps? This is now starting to be more participatory.
Hi, Tanya. Well, you talked about using a secondary uterus contracting medication when oxytocin is used for a prolonged time. So I wonder if that would be one of the next steps.
So that's a second, it's good to think of that and have that on hand, but generally you wouldn't use that unless you needed it, basically, unless she was actively bleeding, which she's not yet. But you would definitely want to consider ergot is great and it's so effective. And there are risk factors to it beyond just the hypertension. That's why we don't use it right away for everything, but we would definitely have it on hand.
Right. So then you're just assessing how much bleeding is there, and ideally you use the actual method, not just guessing.
Yeah. So, you know, you'd have a little huddle and you say, okay, she's at high risk. You should be doing this for everyone now, but generally for someone who's at high risk of postpartum hemorrhage, you really do want to know how much blood she's actually losing. So using the calibrated drape, trying to mop up and trying to catch the amniotic fluid separately so it's not included as part of the weights is all part of it.
I would get somebody to look at the placenta quickly to make sure it looks intact.
Yeah. So next week I'll talk about retained placenta because that's the nemesis with postpartum hemorrhage. And in terms of like when to call and when to deal with all that. But generally like 95% of placentas are delivered.
Oh, we're frozen.
Tanya, can you hear us? Hopefully she'll come back in a minute. I'll just give it a minute. See if she comes back. She might pop out and pop back in again. Oh, there she is.
Oh, sorry. What are the first line? Oh, my internet's unstable. Sorry, guys. What are the first line uterotonics?
Like after we gave our oxy for active management?
Yeah, for active management.
Oh yeah. So ergot, your hemabate.
So that's second line.
Oh.
Yeah.
Oh, like giving a bag of oxy IV? Is that what they're talking? Yeah. Sorry.
Okay.
Yeah. Yeah. So first line would be putting a bag of oxy up. Yeah.
You have an IV already, which is great, right? So generally you want to put a bag of oxy up. Do you want to use the same oxy that you are using to augment? No. So you want to get a second bag, a 500 ml bag of 20 to 40. They're saying 20, 40 doesn't really matter in terms of, or in not a 500 ml bag, sorry, a liter bag of 20 to 40. They're saying that 40, like the oxytocin receptors are going to be saturated at 20. Anyways, it mostly makes us feel better to put in 40. It doesn't hurt to put in 40. So whatever you want to do, but you would want to start the oxytocin. They have carbetocin here. That's mostly for C-section deliveries. But there's actually a trial happening at BC Women's right now to be using carbetocin as the active management for people at high risk of postpartum hemorrhage, basically. So they're using carbetocin. So that it might be, and it speaks to that a little bit in the SOGC that there's more research happening in that. But I wouldn't make that a change of practice right now. But what's interesting is TXA and misoprostol are actually considered a first line med still. So you can put it all together if you like. And so TXA, I'm sure we all know, but it's not a uterotonic, so it doesn't work on the uterus specifically, but it helps with clotting and it's an antifibrinogen. But I was hoping for more clarity on, which I still haven't received clarity after asking numerous smart people, is that whether we can actually use the TXA on the IV that we have oxytocin running on, or whether they need a second line. No, you can't.
According to the monographs, no, you have to have a second line for your TXA.
Okay. They're saying it's because they haven't done the actual safety risk, and the risk is low. And I would recommend that too, because you have a PPH. So you're thinking of a second line anyways. And if you're having significant challenges, or if you're transferring in from home or something like that, it would be really difficult because you have to deliver it over a certain amount of time. Like you want a TXA on a pump and all that. But, you know, it hasn't been shown that it's quite dangerous. It's just that they haven't done the safety testing for it, from what I understand. And then misoprostol. So you can add misoprostol. So these are all considered the first line meds for postpartum hemorrhage. So this is defined as the mild postpartum hemorrhage. So that's 500 to 1,000 mils after normal spontaneous deprivation. It's a little bit different for a C-section. And so they're managing it. They use carbetocin and then they'll jump to TXA. They generally don't do misoprostol in the OR. They might do it afterwards if there's kind of like a slower bleed after, but then they'll jump to second line. I'm presenting. Okay, any questions about any of that? So this is what's actually good to sim, is doing all of this piece. And so the key is that you need an IV, which is sometimes easier said than done with when you have a major postpartum hemorrhage. So the postpartum hemorrhage with the low-lying placenta that I alluded to, I think we got it on the 20th try, but we had like an IO gun ready to go. We were like, it was already running. We were about to open an IO gun for that because we just could not get a line in. And so, you know, calling in the help that you need to be able to get the intravenous line when needed. But any risk factors, it doesn't really talk about a saline lock in terms of risk factors in the SOGC, which I was surprised about. Where is it? Yeah, type in screen notify. So they don't really talk about a saline lock, but we definitely as primary care providers recommend and talk about a saline lock because you just don't want to be dealing with trying to get a line in when they're already at risk. Any questions about that? Oh, where am I? Okay, so you've hung the line of oxytocin, you've called for extra help, you've considered putting an extra line in for TXA or for or giving misoprostol. I would probably give misoprostol and get everything ready to go to put in another line, draw up the TXA, and then just kind of see how this goes a little bit. But you know, everyone's different, and TXA is cheap and it can work quite well. And in the SOGC guidelines, it does talk about how it's improved outcomes significantly. There are risks with TXA, including pulmonary embolism and I think another kind of thrombosis, but they actually haven't shown that hasn't been seen in any postpartum populations. So they consider it quite safe. Okay, so the bleeding continues. Uterine atony is noted, so a boggy uterus. So the one thing that I always do that, you know, a lot of people do it in this steps, especially if the placenta's out and there's frank bleeding. I want to know where the fundus is, where the uterus is to begin with. Right. So you don't have to have your hand on the fundus at all time, and doing continued pressure like that isn't always a good thing, but you want to know where you're starting from and why might that be the case.
So you can note bleeding that's not being able to be seen because it's in the uterus.
Yeah, an occult bleed that's filling up the uterus. And that low-lying placenta, that's what happened. And so anything like that, which it's not always clear, but you want to know. And so if anyone says like, my stomach really hurts, I've got a lot of abdominal pain, often that's associated with the blood filling the uterus. So you want to know where that uterus is starting at to see if it's rising and filling. So uterine atony noted, the heart rate's going up, so she's getting tachycardic, which is the first sign for stage 1 of a postpartum hemorrhage. So you're assuming, hopefully you have it quantified, but you're assuming that she's lost over 500 mils. So what would be the next steps? So the SOGC at this time is actually calling for bimanual compression earlier rather than later. Basically, my next steps in this is you want to know what's happening with the uterus, because you want to know if there's any clots or anything in the uterus. So I would generally go in and check for clots. You know, I do some teaching with UBC midwifery, and the students are often very reluctant to go in and take out clots or check out or remove clots because they feel that it's quite invasive. It's one of the first steps to do is you have, because the uterus is not going to contract if there's a lot of clots there. Reefing on a person's stomach to expel with fundal pressure to expel the clots that way, I find is actually way more intrusive than going in. And I don't take my whole hand in, you don't do that, but just 2 fingers inside the cervix, and you're just feeling, because often they're just kind of stuck inside the cervix, so you're just feeling for clots and bringing it out. And then you have a sense there, because you're always feeling the fundus on the other side, you have a sense of whether it's contracted, and you have a sense of how mushy basically the uterus is. Like if you can feel it contracted and contract down, then you're feeling good. If you're expelling clots and it's just continuing to fill up, or you feel a bunch of clots and you just can't get them and you don't feel comfortable like getting right in there, which is totally fine, you should actually go to a bimanual compression fairly quickly, is what they're recommending until you have higher specialty care. The other good thing about a bimanual compression is that you actually don't need to know where the bleeding is. So we're assuming that it's an atonic uterus, but as we all know, there can be many other areas for bleeding. And the most other common is like a high vaginal laceration, which can be really hard to see sometimes after delivery. And they're actually losing a lot more blood, like actual blood loss, because the bleeding from the uterus is mixed with a bunch of other stuff from the uterus, like decidua and stuff. So if you're doing a bimanual compression, you're putting pressure on the vaginal wall as well. So it doesn't actually, you don't always have to know the source of the bleeding, and bimanual compression can still help until you can get her into an OR, or you can get specialty care with proper analgesia and proper lights and actually really try to figure out what's going on. Does that make sense? Yeah, and generally, like I'm very privileged to work with a great OB called Raz Mula, and basically, you know, postpartum hemorrhage is different than like a trauma, in that generally the uterus plays ball eventually. That's his words. So you're just waiting. So the bimanual compression is you're just waiting for the uterus to play ball with the medication that you're giving. So you're giving that, you've done the first line, you're getting the second, like if you're going to bimanual, you should be getting the second line ready, or you can, sometimes it's just like magic under your fingertips, and it all of a sudden like just like contracts beautifully, and you're like, oh wow, that worked. So, and that's what you're waiting for. Basically, you're waiting for the uterus to play ball. So it's different than when people are talking about blood loss for trauma. So this is the checklist. This is the steps. It's in the supplementary package of stage 1 postpartum hemorrhage. So they're talking a lot. So you're getting another nurse in, you're checking for circulation, airway, and breathing. You're doing bimanual. So they're jumping to bimanual way earlier than I ever have before, basically. You're giving the PPH medications, and they're talking about PPH medications first with the first line, and then with the next. And then hopefully you have the blood work done, and then you're weighing and reporting, and you're actually like reporting it out to the team. So it's not just like you're calculating and keeping the numbers to yourself. You're actually communicating with the team, the regular and cumulative blood loss. And if you can, you're assessing for vaginal wall tears and any other kind of lacerations. Foleys, you know, I often forget the Foley with a PPH, and it's online with the bimanual, like bimanual and Foley, because the uterus is not going to contract well if you have a really full bladder. And I am very anal about just having bladders emptied even prior to pushing or at pushing, because, you know, like it doesn't make sense to have a PPH that could have been prevented from something so simple. And then warmth is actually a big one. So if there's any way to warm up the IV fluids, because they can decompensate a lot quicker if they are cold. So you want to get them warm blankets, warm fluids, and so on. Okay, we talked about that. Yeah. So we go in, get the clots out. There's about 300 mils of clots removed. The uterus responds well to the medications, tone's improved. We had the ergot drawn up, but it actually doesn't look like we need to give it. And the uterus is nice and contracted. There continues to be a trickle of blood from the vagina. So your next steps, if you haven't already done it in this checklist that we go over, is that you want to check for any perineal lacerations, right? And so that's, the primary care providers are well equipped at doing that. And then, if it's bleeding heavily, or if it's very difficult to visualize or anything like that, or of course, if it's 3rd or 4th degree tear, then you would call in for a specialist. Sometimes, and they talk about this in the guidelines, you can also pack the vaginal area. So, because again, you want to put pressure on it, so you can put pressure and just hold it if you can't repair it right away to help it reduce blood loss, or you can do like a fairly big tamponade and put it in. So that's often what I recommend to midwives for home birth if they're transferring in, because you can't always put continuous pressure on the lacerations as you're transferring in, to make sure that you carry with you a couple packs of lap sponges to be able to actually like put a big enough tamponade in that would cause some pressure. Because you can't always see it in the delivery room. Sometimes you do need an analgesia, and you do need specialists and light. Okay, so it was repaired. She's stable. Her blood pressure is fine. Her heart rate's fine. So what's the postpartum care plan? Basically, you check her hemoglobin the next day. You encourage her to take her iron for at least 3 months postpartum. And that's about it for that. And then hopefully with the team, so they're really recommending the debrief, and there is that postpartum hemorrhage audit tool that's at the end of that supplementary package. I don't know, I think it's worth your team whether this kind of PPH, which for me is like bread and butter PPH, requires a full PPH audit tool, or whether, like a stage 2 PPH would contribute, but definitely a semi-structured debrief in terms of what went well, what could have been improved, how did the team work, all that kind of stuff should happen. Okay, 4:58. I finished just in time. I'll just end my sharing. Any questions or concerns with that? So if people came later, there are those guidelines and supplementary package. So I think there's a lot of guidelines that come out all the time, but this is actually one that's worth reading and reviewing carefully. And the supplementary package is actually quite useful.
Thank you, Tanya. That was awesome. It was a great review for me anyways, and just of the updated guidelines. And as a midwife practicing for 20 years, it's interesting to see the fluctuations too, like in the ways, we choose to do things, and trying different approaches and just seeing what kind of results that provides. So thank you. That was a great update.
Yeah, no problem. And everyone will will have a PPH in their practice. So it's always good to review, and just managing it kind of quicker is what everyone's saying. So, and I'll put a plug in next week. We'll go over kind of part 2 of that. So more stage 1 or stage 2 and stage 3 postpartum hemorrhage and retained placenta and all that. So, because it's a lot to cover.